Good afternoon, everyone. I would like to thank AIOS for giving me this opportunity. I'm Dr. Raghav Preetam from Sushila Netralaya, Kurnool, Nellore. I would be trying to speak about all about IOLs. I think it will take 7 hours, but I only have 7 minutes. So I'll try to concise the topic and give the... Oh, okay. Someone else is speaking now. I have the right... Dr. Raghav Preetam from Sushila Netralaya. I have no financial disclosure. To begin with, first I would like to thank Dr. Harold Ridley for his major invention of IOL. And also the second thing we'll all have to be thankful for him is because he never patented the technology. He never patented the technology. We have 3,000 lenses in the market which are able to use and abolish blindness. Moving ahead, I have two real life scenarios. We'll try to understand what type of IOL we are going to use. One is a 50-year-old gentleman who is a software employee. He's a traveler and a hiker as well. He has a normal eye examination and P4 cataract, no systemic disease, and K readings are 44 both eyes. And the other side is a patient is a 65-year-old gentleman who is a farmer with few nebula scars and NO4 cataract. He's a diabetic since 2 years and this is the IOL readings. So will the choice of IOL be same for both of them? What will be the criteria you will use and how do we choose them? To answer this question, we'll have to take into three major considerations. One is IOL considerations, patient selection and surgeon factors. We'll only be dealing with IOL considerations. So IOL considerations, basically the material, most commonly used PMMA for rigid lenses and acrylic. Silicone lenses are very fragile and very thick, so the importance of them has lost. And hydrogel lenses have a greater water retaining capacity but have high propensity to cause PCO formation. The same thing was proved in ACRS Leeming survey and ESCRS survey. Acrylic also has the opportunity to incorporate a chromophore into the material. We have UV blocking as well as blue blocking technologies incorporated. Some of these are the yellow lenses we use. And they come in three forms: hydrophilic, hydrophobic and rollable forms. Hydrophobic forms have greater contact angle greater than 70%, which helps them prevent PCO formation. And also the chromophores helps in reduced impact on glare, improved driving and improves photo stress recovery. These are the various designs we have in the market. To start with the AC IOLs, then we have the iris claw lenses, and the multiflex variant of the AC IOL helped and is still in use, and the artesian variant of iris claw we use for our secondary IOLs. And then we have a lot of foldable IOLs including the multifocals and the accommodative IOLs. So basic design has an optic and two haptics. It can be single piece or multi-piece, and the optic edge we'll be talking a little later. So the edge profile, when it is more square edged, it sits very well on the capsule and the chance of PCO is much less. Apart from the edge profile, the location of haptic over the optic, whether it is more anterior or posterior, will also determine the PCO formation. The more anterior the location of haptic is, the chance of PCO formation is less. And the haptic design, the new Technis 2 have come up with frosted haptics which sits very firmly into the bag, helps us in our toric lenses. The same thing with IQ, which has stable force haptics, whereas the Hoya lenses have a textured rough haptic surface which helps in rotational stability. One word about spherical aberrations. These are the high order aberrations which have caused some visual troubles of late. Using an aspheric lens, we can focus both the peripheral rays and central rays onto the fovea, giving a crisp vision, improved contrast sensitivity in mesopic conditions and decreased total high order aberrations. How do we choose the lens? We have three lenses in the market. One is Technis, Acrysoft IQ and Softport AO. So which in cases with corneal irregularities, it's not a good idea to put an aspheric lens, or whether it's better to choose a zero order spherical aberration lens. Toric IOLs, there's a talk next to me, so I'll just skip this part. And then we have a concept called as enhanced monofocal, which are the pseudo EDOF lenses. One is the Technis iHance lens, which works on the refractive technology and continuous high order aspheric surface. As you can see, there is hardly any difference between the Technis iHance and Technis one piece. Clarion uses the residual spherical aberrations to improve the depth of focus, giving us the enhanced monofocal effect. Refractive multifocal lenses are out of practice, diffractive lenses are still in practice. However, the intermediate vision is not as good as we have seen. So we are now in an era of enlightened optical technology, of the quadrifocal technology of the panoptics, where instead of one gradation, they have 3 gradations, and whatever the stretch, as you can see here, it helps us for enhanced contrast for the distant vision. So one word about the EDOF lenses is the wavefront shaping technology of the VVT, which we have, helps us improving the intermediate vision as well. I'm running short of time, so I hope I helped you choose the lenses for both the patients. My choice for the first case would be an Acris of VVT, and for the second case would be a non-aspheric lens like a single piece or a Technisensor lens. Thank you.
You're talking about 3 different types of aberration, 3 lenses, aberration corrected lenses.
Yeah. Yes, sir.
I thought finally you will talk about that for these two patients.
So the Acris of VVT, as it is, comes with an aspheric surface. So it does prevent the high order aberration. In the sense, it does prevent the spherical aberrations. And the second IOL, why I chose an non-aspheric lens is because the patient had couple of opacities in the cornea. That's the reason I put both the cases. Thank you.